For many people, going to hospital feels reassuring. You get sick, you go in, they fix you, you come home. But here's the uncomfortable truth. Our hospitals aren't full because older people are unlucky. They're full because we are late. Late to notice the muscle loss, late to question the medications, late to act on the drift in balance or memory. The average hospital age in this country is 85. And at 85, hospital isn't neutral, it's destabilising. Strength drops, frailty accelerates, and sometimes people don't get to go back home. So today we're asking a better question. What if we focused on preventing admission, not just managing it? I'm Hannah McQueen, and this is The Next Bit. And joining me is Dr. Cheryl Johnson, lead geriatrician at Brightly, someone who sees every day what hospitals do to older bodies, and more importantly, what families can do about it. Cheryl, most people don't plan to go to hospital when they get older, but when they do, it's a big deal. Why is that?
Yeah, as you said in the intro, our hospitals are places where there's lots of older people. So the average age of the person actually in hospital, so that means they've got through the emergency department and they're now in an inpatient ward, is 85. So, our hospital wards are full of older people. And as we've talked about in previous podcasts and you've done in your other podcasts, we've done a really good job of longevity, and we've done a really good job of allowing people to live well for good periods of time. And then older people have this sort of downhill trajectory that can happen over several years. So if patients or people start coming into hospital and they're unwell, often they know that they're on that start of that journey, that they're on that start of that trajectory. And, hospitals are quite scary places. It's not a place that people want to be in.
But it still can be reassuring for the family though, right? Like you're like, well, thank goodness mum's in hospital now. That at least they know what they're doing. But it actually, maybe that's a false sense of confidence.
I think in some ways it is. I've always said that hospitals are dangerous places for older people. And let's first of all say that that's not because of anything that any individual doctor or individual person does. It's just the environment that we're putting our older people into. And, we put people in bed and we treat them well. And I think, patients start to get a bit institutionalised. They get used to us looking after them. I think they start to know that they're on that trajectory, that their conditions are progressing and that they're starting that decline, which I think is quite confronting. It's quite confronting to the person to know that things are changing.
What are the main reasons why people get in hospital? Because although the average age of an inpatient might be 85, that suggests that half of people are getting in a lot younger than that, right? For that to be the average. But what are the main reasons older people, and let's define older people, from 60, 65 upwards, what are the main reasons why they're ending up in hospital?
Yeah, and you're right. Emergency departments do a really good job in turning people around, and they do a really good job in turning around older people too. So obviously if you're getting into hospital, into the inpatient wards, you really need to be there. The biggest reasons I think older people come into hospital tend to be things like infection. So respiratory infections, pneumonia, influenza, COVID, those types of respiratory infections where people have difficulty breathing and need to come into hospital. Older people obviously are going to come into hospital for elective procedures, hips and knee replacements and things like that. Other conditions that older people tend to get is things like heart failure. So their heart doesn't pump as well, and that starts to have respiratory symptoms. Stroke is common as we increase in age, and then things like heart attacks as well. And so the sort of cardiovascular diseases tend to be the reasons why people are coming into hospital. The other big one is falls. We've talked a bit about falls in the previous podcasts. That's a significant risk for an older person, whether or not they injure themselves. Not all falls result in injury, but even people who don't injure themselves or break a bone will come into hospital because of that injury, and because of that fall.
and that accelerates, like they might be discharged, but they're more likely to be back in hospital within 3 to 6 months because that was actually the start of, or an objective start to an accelerated decline.
Yeah.
So I'll just check whether my estrogen patch is working. I'll see if I can remember some of that. So the main things that we're saying are putting them in hospital, putting aside the elected surgeries, because we want those, that they are planned. It's the unplanned we're talking about. So that tends to come from medication, short-circuiting, mismanagement, or something happening that's making you lose balance or feel dizzy or unwell, falls, respiratory, cardiovascular.
Yeah.
How many of those are preventable if we got to them early enough?
I mean, yeah, that's really difficult to put a number on that. But yes, absolutely, things are preventable. If we take respiratory infections, for example, we take influenza, we can vaccinate against that. We can vaccinate against COVID. We can vaccinate against something called pneumococcus, which causes a large proportion, I think about 80 to 85% of all pneumonias are caused by this particular bacteria. So we can vaccinate against that. We talked about heart failure. So heart failure, the heart pump itself starts to fail. A lot of that management can be done in the community once we know that that's the problem. So, patients themselves can self-manage. They can weigh themselves and they can be in contact with either a nurse or a doctor and adjust their medications. And there's clues that things are deteriorating and that they do need to adjust their medications by their symptoms, their breathlessness, and also what their weight's doing.
So they need to know that they need to measure it.
Yep.
How do they know that? If they're waiting for a symptom, a soft symptom might be breathlessness, or ideally you want to manage it before you even get to the breathlessness. So how can you know about it?
So for an older adult who's got symptoms and thinking, things are changing, my body's changing, I'm not walking as much as I used to, or, I'm getting breathless going up a hill that I used to be able to walk up before. My sleep at night's not so good. I'm not breathing as well at night. They're all symptoms that might suggest, let's get an assessment, let's see what's happening and make a diagnosis and then move on to management. I guess one of the other things is also preventing the reasons why you might get heart failure in the first place. And so that's, keeping your cardiovascular health as good as you can, preventing heart attacks and keeping other things like heart rhythm abnormalities really well under control.
The other reason why people go into hospital that I've read is that they just can't cope anymore. So there is no real medical emergency apart from it's the end of the line for perhaps giving care or being able to manage yourself. Is that something that you see?
Yeah, that's what we sort of term the social admission. It's not a term that I like to use, and it's not a term that I personally use, but it's one that you do see. And the reason why I don't like it, I think it sort of blinkers our thoughts as to what's happened. And we talk about some of those attitudes that people have towards older people. And if someone's coming in because they're a social admission, it's because something's actually happened. Something's gone wrong at home. A lot of patients or a lot of older people live on this knife edge, and that relies on them having support structures in place to keep them at home. Something happens, the caregiver doesn't turn up, the caregiver gets sick and they don't come for a day or two, or the daughter goes away on holiday and the daughter was really supporting that person. Something changes and then everything, results in a hospital admission. The other thing that often will happen is the spouse gets sick. So the spouse goes into hospital for, whether that's elective or not, acute. The spouse goes into hospital and they've been looking after their partner, their spouse at home, and other people haven't really realised what's happening for that other person and that they've slowly been deteriorating, maybe cognitively or physically. You take the spouse away and that person actually can't manage without their support structures, and things fall over, literally and metaphorically.
Good grief. Okay, so take us through a scenario where you might come in for something that is treatable. and you're admitted maybe because there's complexities or whatever happens in that clinical setting that I kind of brush over.
Yep.
And that is one of the reasons why people often aren't discharged out of the emergency department, right? It's like we've actually got to do, there's more to this, or there could be more to this than what we're first seeing, and that more to it takes time and normally a multidisciplinary team assessment. So off you go, waddling into the ward. But you come in for something that, let's say, is quite inane. Don't even know what that means.
Innocuous or mild.
Mild, yeah. Mild, thank you. But you go to hospital and it actually creates a domino effect in the wrong direction. That's the bit that we need to understand. Can you bring that to life for us?
Yeah. I'm going to do quite an extreme example, but it's actually not that extreme. So let's say you have a fall.
Yeah.
Or let's say, you might have been out in the garden and you might have, hurt your back, strained a muscle. Okay. You've tried to sort of manage it at home. You might have gone to your GP and, got some medication to try and help your pain, but your pain gets worse and worse and worse to the point where you're in bed, you actually can't get out of bed, you can't look after yourself, you live alone, you come into hospital.
Mm-hmm.
So you get into hospital, and if you can't walk, we can't send you home. It's as simple as that. So that person will then get admitted. We'd look at their pain relief. A lot of the pain relief medications we give, like opioids, like morphine and codeine and things like that, will cause constipation. So the person gets constipated. When you get constipated, you get urinary retention. So the bladder doesn't empty properly because of structural and anatomical changes. The person's also not walking, and that's not great for your bowels either. So that kind of exacerbates the whole constipation. I haven't finished yet. So their bladder stops working. We put a catheter in. Catheters is more. The catheters get infected, because there's a tube going into a bladder. So now we've got an infection, so we start you on antibiotics. Some antibiotics, because of what happens in changing the natural bacterial flora or the bacteria that sits in your gut, you can get overgrowth of another bacteria, which then leads to diarrhea. And that can actually be quite serious.
At least your bowels are working at this point.
Okay, we've fixed one
lining.
problem. Sorry, we've fixed one problem here. So, all the while, this person's in bed because they're unwell. They've got a catheter in, so they don't have to walk to the toilet because they don't need to. They're a bit constipated, so they're not, we're trying to get their bowels going. So their muscles weaken. And then, they might get up in the night, or, they might be trying to just even get out of bed or sit in a chair. They have a fall. If they have a fall, they might break something. You can see how the spiral kind of continues. One thing leads to the next, and as you said, that domino effect. That's extreme. Usually it may be 2 or 3, but sometimes you do get a whole lot of things stacking up against each other. And then in that, there's things like delirium. So if someone's at risk for getting delirium, which is an acute brain failure, i.e. the brain's not working properly, if you're at risk of that, say you've got cognitive impairment or dementia, we add in medications which can make that worse. You add in the environment that people are in. Hospitals are quite strange places. There's not always a lot of natural light in every
And you're not
room.
sleeping usually, right?
Well, you're not sleeping. People wake you up in the middle of the night to take your blood pressure. So you're not, you're constantly woken up. There's just so many things that happen that just make the whole hospital admission really complicated, and just things can get worse and worse and worse and worse and worse when the original problem was, as we said, quite minor.
Yeah, you shouldn't have been doing the gardening on the Saturday. You wouldn't have hurt your back, and then off you go.
Yeah. Although good to be getting out.
I know, I was just thinking.
Active. So you've got to, you've got to kind of temper it a bit.
Damned if you do, damned if you don't. Okay, so a couple of things I want to pick up there. When you stay in hospital, the longer you stay in hospital, they say that you start to lose strength or something like that. What's that?
Yeah, it's a condition or a phenomenon we call deconditioning, so that all muscles weaken. Mm-hmm. So you and I, we get sick, we get the flu, right? We're going to go to bed. Even if we're in bed for 2 or 3 days, all of our muscles start to weaken. For you and I, we feel a bit rubbish, and we can sort of manage it. And, over the next days, once we start getting back into our routines, we gain that muscle mass back. But if you're an older person and you're in bed for 2 or 3 days, all your muscles are going to weaken. And the important ones are going to weaken too. respiratory muscles, so your big diaphragm muscles and all those muscles around your chest weaken. Your muscles of swallow can weaken. So then you now have problems swallowing food or fluid. That might go into your lungs and cause an infection. If you're smaller, you've got less muscle mass. So you've got, less of it to lose when you start to decondition. As we age, our muscles also change. It's for everyone. The muscles themselves get a bit smaller, and they also have more fat within the muscle fibres. And that's an important thing when we think about drugs and how drugs work, but also the muscles themselves aren't as good as they used to be. So a few days in a bed, people are going to weaken, and then it's going to become harder to do activities. So your big, shoulder muscles, your big glute muscles, your big thigh muscles are all going to start to weaken. Then it becomes really hard to try and get yourself out of bed.
It sounds quite depressing. And I was actually just thinking my glute muscles are already weak, so I don't know what's in store for me there. So if we go back to, I guess we want to make it clear, if you need to go to hospital, go to hospital. This isn't about pretending you don't need to avoid going. I guess the main message is we're trying to keep you legitimately away from that point in kind of a decline trajectory. Is that fair?
Yeah, and I think it's about that proactiveness. Often people will stay at home until they can no longer, cope with what's happening with that acute illness. So it's really about, as we start to see the changes, getting onto the GP and saying, Mum's not feeling right. Mum's not right. Can we get onto this? Or the patient themselves saying, I'm not feeling right. Let's get into this and get this sorted. I think one of the concerns that we've talked about with, the challenge within our stretched GP services is that it can be quite hard to get an acute appointment, or actually more to the point, I think people think that there is no ability to get an appointment with their GP, so they don't even try. Lots of GPs have acute appointments in the day specifically for this reason.
So just talk about acute appointment, because most of us, including myself, don't actually know what you're talking about.
Doctors talking a language all of their own. So GPs will keep, maybe 2 or 3 appointments in the day for the urgent stuff. So if someone's really unwell, or, someone has a fall and might have broken something. So the things that aren't necessarily the chronic
problems. Really?
Like I do. Yeah, they do.
So they have assessed my emergency as too low to get over the threshold of these acute appointments. Okay, so there's something there. But even if you could get to your GP, a lot of these people, and I think GPs are amazing.
Absolutely.
They've been to their GP before. Often it's reoccurring, which is probably the sign that we need to do something else because this actually isn't working. But you go there, you have got 15 minutes, which is really enough time to deal with a sore throat, not really enough time to work through your medications, your respiratory, your urinary, your cardiovascular, and your neurological. I can't even think of any more words, but there's so many more words there. Are we sending them on a bit of a wild goose chase? Because I would be, if I'm talking on behalf of my mum, if she's experiencing something and we're saying, we'll just whip to the GP, obviously we've got a solution outside of the GP. But to go back to the person that you've already seen 10 times and you're not being heard the way you might want to be heard, what do we say to that person? Because I hate it when we say something trite. I know you're definitely not doing that, but if people are trying to go, well, I've been there, I've done that, to them it felt like a waste of time and money, even though I don't imagine it was, and I believe the GP would have been incredible. But even if I look at my beautician, who's 73, she's amazing, great skin, and she's amazing. She's been to her doctor 15 times in the last year, and she's telling me this and she's crying. For me to say to her, just go back to your GP, doesn't feel right. But is that, unless you're doing something as proactive as Brightly, that really is the only solution that the current system offers. Is that fair?
I think it's important to kind of separate acute illness, like something is happening right now that's different from all those kind of chronic things that sort of are under the surface or are bubbling along. So we said before, infection, really common cause for older people coming into hospital. You can see the signs of infection early, and if we get onto antibiotics and manage that, that might stop the person coming into hospital.
Gotcha.
Also the vaccination we talked about even before that. For example, if you've got a loved one with dementia is if someone gets unwell, they might get delirium. And the first sign that they've got an infection might be, mum's not right, she's really confused, or she's just doing things that is really not like mum. And that's often a sign to say, there's something going on here, there's something acute, and that needs to be assessed by the GP and managed. There's all the other kind of chronic conditions. There's the underlying dementia for that person. There's their falls risk. There's their bone health. There's all those other things going on. But we're just talking about this one acute problem that we need to intervene in and stop them from coming into hospital.
Absolutely. It's just interesting you say that there's time for those acute patients, but if you are the daughter calling up the GP to say, because mum clearly she's away with the fairies in this particular example, or something's not quite right, so she's not calling the GP, she's probably threatening you if you even think about calling the GP. So, but you call the GP, we call the practice manager or receptionist, and you're trying to say, well, mum's just not quite right.
Yeah.
Is that genuinely going to get you to the top of the queue for an acute need, or is it that, we're going to have to wait a few weeks? Because I wouldn't have thought that would be above a threshold to get urgent care. Certainly if you're having a heart attack, get to the GP or whatever, the hospital. I'm not trying to stop any of those things. But then you go to your doctor in 3 weeks' time and you say, mum's not quite right.
I guess, in that situation, saying, I think mum's got an infection.
But how would I know that about my mum?
That's because you're an expert in your mum. That's the thing I think families don't always recognise or think about, that they're actually an expert in that particular person and they know when there's changes. So you can say, mum's really confused. I think she's delirious and I think she's got an infection would be words that I would go, oh, yeah, we need to see this person. We need to get that person in, get them on antibiotics and obviously diagnose whatever infection it is. And then
and that's what the GP can do in that situation.
Absolutely. Okay. And try and prevent them from coming into hospital, with their respiratory illness or with their urinary tract infection, because if we've left it, things just get worse and worse and worse and worse and worse, and now they're coming into hospital.
That would be so annoying. That the thing that put you in hospital was a UTI. Can you imagine?
That happens a lot.
That's heartbreaking. Okay, so if it's acute, your GP's there, but if you have got these chronic conditions, some of them you don't know about, or some of it the change is so gradual, and that's maybe you can spot an infection, maybe. But that would suggest almost a sudden change. But a lot of these conditions, it's so gradual that you become acclimatized to it and you become acclimatized to the slow decline. And it's just like, this could be accidentally quite dangerous, inadvertently.
I guess that population of people may not necessarily come into hospital acutely, but back to your beautician who's
same no joking
lots of things that in common. As you said before, getting that assessment, it is really hard for GPs to do it. You and I have already talked about this on the podcast, that GPs have that limited window in which they can really just deal with one or two problems. But having a service like Brightly where we can look at that whole of person and understanding things that the patient or the client really didn't know what was happening for them. And then the education. So we can say, okay, these are your risks. These are the areas you need to focus on. This might be what might happen, that sort of roadmap. I will often say to patients or family members who've got people with dementia to say, these are some of the things that might happen. They might get delirious. This is what you're looking out for. If that happens, you need to act.
Mm.
Emergency departments are also another space where people can go. If you can't get into your GP, as I said before, ED or emergency departments, are really good at turning people around and getting people out. And so they can do an assessment. They can check, they can do a chest x-ray, a urine test, get people on antibiotics and get them out again. So that is still available to people. And just because you come into the hospital doesn't necessarily mean you're going to get admitted. And we actually try hard not to admit you when you're older because we know the risk.
Okay, so we go back to the hospital. We're trying to prevent that. So let's look at the most common things that we could prevent. Falls risk, which you've said a couple of times. If you're in your 60s, what's one thing we could be doing now to prevent falls risk? Because it's more than clumsiness, right?
Yeah. I guess for those in the community, the things that we can do in terms of exercise. So we know that exercise reduces falls risk. The thing about exercise is you can't bank it up, unfortunately. You can't do some now and go, oh, that's going to protect my falls risk down the track. It doesn't work like that. You've got to keep doing it. So you've got to keep up.
It's annoying, isn't it?
I know, I'm sorry. It's just the way of it. So, that regular aerobic exercise, which is walking, and then some strength and resistance training as well, and some balance exercise. So we know Tai Chi is really good for balance because they teach you ways to control your balance. And the thing I love about Tai Chi is that it's for everybody, for all age groups. And people say, oh, I'm not very good at standing on one leg. And I'm like, it doesn't matter. You can actually do Tai Chi in a chair if you wanted to, if you're not that strong. And then you just keep building on it and keep building on those exercises and strengthening. And so it becomes a really good exercise for people.
So looks like we're all joining a Tai Chi class.
Well, we've just promoted Tai Chi for everyone because it's good for them.
But if we say, okay, well, that's your falls. That's the balance and the strength component or the fitness. But there are other things that lead into falls risks, which I don't think a lot of people clock around the medication risk, the cognitive decline, the lack of sleep, reducing oxygen to the brain, your home risk. There's sort of all these things that have nothing to do with the strength and the balance. How do we improve? Because I was astonished by that there were all these contributing factors to whether there's a falls risk, and most of those things in your medications, you don't even know. And when it comes to medications, you probably think, well, it's been prescribed for me, therefore it must be safe, which we'll talk about in a second. But how can we lift the awareness around what contributes to falls? What's something that we could do on that?
Yeah, you're absolutely right. There are specific, what I would call red flags for medications that do increase falls risk, and that's around knowledge. So, I can look at a list of medications and go, oh, I don't like that one, I don't like that one, we're getting rid of that one, because I know what the risks are. Not everybody is trained like a geriatrician is. And so, one of the things we do at Brightly is we look at the medications and we say which ones are causing harm. And that might be falls risk, it might be cognitive function, or it might be other risk. And we come up with a plan for how we're going to manage that. Yes, dementia does cause falls risk or adds to falls risk. And looking at how we manage dementia, and what we can do to stabilise memory or to improve memory. And then we've got to kind of look at the home environment. And, not everybody's home is set up that's functional for an older person, and particularly an older person who's got a walker. People love rugs. They make everything look nice, but they're not great as far as a trip hazard goes. And there are other things, age-related changes, or not always age-related changes that can happen to an older person to affect their balance. Things like we can lose feeling in our feet as we age, and so then it does get a bit grim. So our feet become numb, and when your feet become numb, it's not giving enough information to your brain to say, where are my feet in space? And therefore, how do I actually move them in space? So that's when people start to say, I feel wobbly and I feel unbalanced.
I have no words to some of that stuff. I was just thinking, I was dooms playing in my mind. I thought, imagine if you got a UTI, your feet started to get a bit numb, you tripped on the rug, like just a cluster of avoidable things, and then you're in hospital.
And the thing, when I think of falls, goes hand in hand with that is bone health. So, you know, we take the example of the person who trips over, the feeling in their feet's not great, their balance isn't so good, they trip over the rug, they've got a UTI, and then they break something. And then that is, as we talked about in previous podcasts, a hip fracture is a central event for somebody.
What does that mean?
It means that life is going to change. Life is going to change dramatically. It is not going to look the same way as it used to. So that means often will mean going into a rest home or a nursing home or a private hospital.
So when we say we've got to try and prevent these things, it's because the events that happen after that hospital admission, or if we say you might not be going home, it's because you would be going to a rest home. We're taking that seriously, and that the prevention doesn't start the month before or the week before. It doesn't start with you sorting out the rug the week before. We're talking years, sometimes decades earlier. We can change. We have the power to change a trajectory, which gives me tingles.
Exciting.
It's incredible, but we need people to appreciate that, because sometimes when they think, oh, well, if I'm going to be in hospital at 85, I'll start worrying about it at 84. And so, no, that hospital event that became kind of the critical next stop, you're at a rest home, normally it's preceded by earlier hospital events that weren't as significant, but they were demonstrating a problem and accelerating a decline. Would you agree?
Yeah, and I think one of the things in the clients that we're seeing in Brightly is we look at their bone health. It's something I find really important and an area that we should be looking at. And we're often suggesting to our clients that actually you might have osteoporosis, you might have weak bones, and people are like, but I'm fine. And, we're saying, let's think about treatment. Let's think about drug treatment to improve this. And they're like, actually, no, I'm fine. And it's because some of these diseases are hidden. Some of these diseases are invisible until, there's your broken bone.
Because it wasn't just that you fell, it was that the fall caused the break. And it was the break that meant you were in hospital for a whole lot longer. And the break then led to this functional decline, which then made it
care.
Exactly impossible for you to return, and off to care you go. And yeah.
So if we can say, let's treat your bones now, and a lot of our treatments don't actually, what they do is they stabilise bone, so they keep you at the density of your bone where it is now. They don't necessarily build bone. So if we can kind of say, okay, you're a female, you're past menopause, your bone density is this. If we lock that in at this level, we're going to stop you from continuing to decline.
Okay, that sounds great. But you've got to know.
It's the cell, and it's making sure that patients or our clients understand that because it's an invisible condition. It's not like I'm getting breathless or I've got a cough or it's something that I can see. It's really invisible, and sometimes people don't always want to kind of face up to that and actually think, oh my goodness, aging is starting to come in. So we've got to really empower people and say, let's give you a treatment. Let's give you an injection of medication every 12 to 18 months. And you might only need it for 5 years, and hopefully you're good. And hopefully you never have a fracture, and we never have to go down that pathway and that spiral that happens for older people.
Back to the medications, I think a lot of people think that because it's been prescribed, it's safe, but that's not always the case, or is it?
No, it's not always the case. Geriatricians are really trained in medication. So what we call the science we call pharmacology. So we know a lot about medications. We know a lot about how they work and the effect they have on the body. And we need to know that because as you age, all of that changes. So your kidney function changes, your liver function changes. So you can't actually break down the drugs the same way. As you get older, you're more likely to be on more tablets, and all those are kind of interacting together. And often medications in older people can have harm. So if you ever ask a geriatrician, what's the most harmful medication, we'd say anticholinergic medications, and everyone looks at us going, oh, what are they? So they're a group of medications, and they're quite wide, that have very specific effects on the brain and what we call the cholinergic system, and they cause a very specific set of symptoms. And one of them is causes visual changes, causes changes to your heart and blood pressure, so that might then increase your falls risk, makes you confused.
That sounds terrible. Why would we be on this drug to start with?
Because not everybody knows that they're unsafe. Not everybody has that core knowledge that geriatricians have. It's really hard for any doctor to stay across everything. Even as a GP, really hard to know across everything. And that's why we have specialists. That's why we have people trained in those areas who can look at something and go, that's not going to be safe. We need to do this. We need to adjust things. And, some people have been on medications for years and years and years. And nobody's, when they started, it was probably okay and it wasn't risky. But things change. People get more, just the diseases, more conditions, more drugs, and then things progress.
Okay, so in a perfect world, we would have started working with these patients. We call them clients at Brightly, kind of in your 60s. We've got this baseline so we can track any change really, really early and respond quickly. But not everyone listening has been a client since 60, especially since we've only launched in the last few weeks. What are some symptoms that we should be paying attention to or be slightly worried about if we're observing them either in ourselves or our family members, so that we can actually be aware to then do something, which could be going to your GP, or it could be just trying to jump to the front of the line at Brightly and we do everything at the same time. But what are some of those symptoms we should be looking out for that you can't just put down to, that's just aging, can't do anything about it?
Near falls are a really good example of that. So a near fall, like it says on the tin, is you almost fell but you didn't. So if you ask anyone who's a faller or who's had a fall, you're going, well, how many times did you almost fall but you didn't? And that was because there was someone they could grab hold of, there was a wall, there was a piece of furniture or whatever. That is a flag for me to go, okay, we really need to assess your falls risk and work out what's driving that, and then try and put steps in place to improve that. Another concern is people who slip off beds. So, always a red flag for me.
How are you slipping off a bed?
Well, that's right, because you and I don't ever think about it. But if you ask older people, they might be sitting on the edge of the bed and their core strength is not good enough or fails them in that moment, and they'll slip off. And that tells me they might be on the way to getting frail. So that's an area where we need to think about intervening, thinking about exercise and nutrition and medications and all those sorts of things.
Mm-hmm. So an air fall, a random slip.
Yep.
What else? Dizziness?
Yeah. I mean, dizziness is a complex symptom. But you've really got to take the time to tease it out. If I see a person come in with dizziness, I usually have an hour and I've got to kind of tease it out. Often it's a balance thing. People find it really hard to describe symptoms. So, they're saying I feel dizzy, but actually they're unbalanced. They're unbalanced. We need to work out why that is, because they're going to fall if we don't work that one out. Pain. So people who have joint pain will potentially be a falls risk as well, because if you've got a sore hip or you've got a sore knee, You're walking along and suddenly your knee will go, sorry, mate, I'm not staying up, will give out and you'll fall. And that's certainly a risk as well. And when you have, say, let's take a knee pain, you might have arthritis in your knee, all the muscles around that joint start to weaken because of what's happening. And then, as I say, you're walking along and you get this sort of, I'm going to say incorrect, it's not quite the right word, but the muscles contract in the wrong way and you're over. So our Brightly assessment looks at things like pain and saying, well, how can we manage that? And also, medications, you're on the right pain medications, and is that also increasing your falls risk? So it's everything kind of interlinks and is all interwoven.
Okay. We'll do what we can to prevent. But let's say my mum ended up in hospital, she's there now, for whatever reason, we never got to it, or it was just happenstance, whatever, she's in hospital. What are we supposed to do once they get admitted to hospital? Like, as a well-behaved daughter, what am I supposed to do in that instance?
Yeah, it's first of all, getting to understand what's happening. So, trying your best, which I'm going to say is quite hard, but trying your best to catch the doctors and talking with them and trying to understand what's going on. And, understanding from the nurses also what's happening. If we're educated, if we've got some understanding of the risk, then you as the daughter or as the son can help mitigate some of that risk. If you know that mum staying in bed is not the right thing for her, and provided it's safe to get her out of bed, talk to the nurses first.
I don't want her slipping off the bed. Good grief. I don't know if I should be touching anything.
But actually just asking the nurses and go, I kind of like to take mum for a walk. Is that okay? What do I do? And they'll probably go, yeah, that's cool. This is what you do. Grab the walker. This is what we're going to do. And, take mum for for frequent short walks.
Are we talking up the ward?
Yeah, even just in the room and back again, or just a little bit out into the corridor and then come back again. Or even just the simple bed to chair. So, that moving from lying in bed to sitting up in a chair is really good. So when we lie in a bed, our lung mechanics change. So when we lie in a bed, we don't actually use all our lungs because we don't actually need to. But when you sit up, you're actually using that whole of your lung. And what that means, it might not seem like a big deal, but if you have parts of your lungs that you're not using, get something we call atelectasis, or just the air sacs aren't opening, that's a risk for developing pneumonia. And talking to the nursing staff and talking to the allied health staff, so the physios and the occupational therapists, and trying to understand what's happening. You can talk to the pharmacist. A lot of wards will have pharmacists, and talking with them and trying to understand what drug changes are happening and just getting that understanding.
So I recognise that, but when I've gone to hospital for whomever, I can't find anyone for hell or high water, and I'm certainly not able to find all those people that are there that clearly are still looking after a parent. So what can I do then? Can I ring a bell, or what? How do I get them to come? Because you say they're there, but as the daughter, I don't see it. Because the things I want is, I want to know what's happening. What can I do? What does mum need to do? Can I get her a different room? These are things that I'm interested in. She didn't sleep. She's grumpy. She's going to slip off this bed. Yeah. What are we doing about this?
Yeah.
And then you look at these nurses who just work so hard, doing an amazing job. I don't want to upset them, but I'm worried about mum. How do I navigate that so that I'm useful without poking bears I'm not meaning to poke?
It is difficult because hospitals are busy places. You said at the beginning, they're full. We run at actually probably more like over 100% occupancy. It isn't easy. There are better times to come into the ward than others. Doctors are creatures of habit, so we're best seen on the wards in the morning. So trying to come into the morning, and I know people work. I get that. I'm a working mum too. I understand that, but trying to come in early and catching the doctors and being there. Or, talking to the ward clerk. So all wards have a clerk or a person who's at the front desk and saying, look, I'm really worried about mum. I want to talk to someone. Can I make an appointment to talk to somebody? Or, can I talk to the charge nurse? So the charge nurse will often not have a patient load, but they're not actually hands-on looking after patients, but they're looking after that whole ward. And they usually know what's going on for the patients, and they're a really good resource to say, can we just have a chat? Can I understand what's going on? Okay. I want to talk to the doctors. And as doctors, we want to talk to you. It's a two-way street. 100%. Yeah, because as I said before, you're the expert in your mum. I'm not the expert in your mum, to be honest, although your mum's had an assessment. But you're the expert. You know what is important for mum. You know what she likes, what she doesn't like, what's important for her. So you're really important as a partner in that. I'm painting a rosy picture. It's not always kind of that rosy, and we do have adverse or adversarial conversations with families. And I always start that by saying, we're all on team mum. We're all on team insert name here. We're both on the same side. I'm not on one side and you're not on the other. We're on the same side. We have a common goal or a common aim, and that's to get your mum out of hospital. And we need to work together towards that aim. And usually that does work, and people go, oh, okay, I get it. I get that we're working together. And then opening up that conversation and saying, what are you, you're fearful. What's that about? What are you worried about? What can we do? And it's just working together to say, okay, what can we improve here? And fear motivates or fear makes us act in ways that are often adversarial, because we've got someone in the hospital bed and they're changing, and it's scary. If someone's sitting there and they're unwell, they've got an underlying dementia, they've got an infection and they're delirious, and they are not the person that you know and that you love, it's really scary. You're sitting there thinking, oh my God, is this what my mum's going to be like permanently? But we work together and we say, okay, this is what's happening. You understand, and this is how we're going to work towards that.
Okay, so we're going to turn the conversation on its head to try and wrap it up, because I don't want my mum to be in hospital.
No. So let's try not to get into this.
Rosie as you paint that, it's grim, and it's really sad to see someone you love there, and you can see the fear in their eyes when they are there, and you're powerless. So let's keep them out of it. How do we keep our parents out of hospital? What could we do? And let's
put the positive frame on it.
Let's be proactive and let's own the space and invest in our health and do something that's actually going to be meaningful and useful. How does that show up with Brightly?
As we've talked about before, it's understanding where you are at the moment. So it's that whole assessment. And, our assessment has 16 domains. So it's really comprehensive across a whole lot of areas. And we're saying, these are the things that are going well for you. These are the things that we need to really focus on. And these are some risk areas. And looking at all of those things, and we don't do it all at once. This is a process. We don't say, we're this, because I think that's really overwhelming for people. So we just say, okay, we're going to guide you. We're going to work with you with our health coaches, and we're going to really just step by step work our way, towards getting you stable or improved in terms of your health and managing all those conditions, and really empowering you to understand what's happening to your body. It's these are the things that I see all the time. These are things that I can look at a person and very easily understand what's happening for them. But it's about getting that knowledge that's in here and in all geriatricians' minds out to the people that we're looking after and the people in our community.
Is aging, last question, is all aging decline inevitable?
We know that aging affects all organ systems. We all get older. It's a reality. And we have changes in our lungs, we have changes in our heart, we have changes to our brain, we have changes to our muscles, all things we've already talked about. We can slow some of that, or we can understand it and put steps in place. So if our muscles are starting to weaken, we can exercise them and we can improve them. If we think maybe my brain's starting to slow a bit, there's things that we can do. We can, again, physical exercise will help our memory. We can, make sure that we're on the right medications and take out maybe medications that are causing harm. We can think about brain training exercises if that's your thing. We can think about social engagement. There's so many things that we can do. Hearing loss, hearing's an independent risk factor for the development of dementia. You can fix your hearing. Amazing. Good story on that one. My dad, he's had hearing loss for a really long time and realised that his hearing aids weren't working. And I was like, Dad, I know your hearing aids aren't working because I'm talking to you in my geriatrician voice, which is a lot higher, a lot louder and a lot slower. He got new hearing aids the other week and I'm like, oh my God, you can actually interact in this conversation that I'm having with you and Mum, and you're hearing everything. And it's so much better because everybody was noticing that it was bad. And, something so simple as improving hearing aids has made such a difference. So if we can end on something more positive, there are things that we can do to stop that aging.
Reverse what we can, slow what we can't, and better manage what's left over.
And understand what's happening to you.
Yeah. Thank you, Cheryl.
Thanks, Hannah. Nice to see you.
An 85-year-old in a hospital bed is very rarely a sudden event. It's usually the visible endpoint of quiet, gradual drift. But small changes, early action, and the right assessment can make a massive difference to how someone ages and whether hospital admission is fait accompli or not. Because staying out of hospital isn't luck, it is strategy. At Brightly, we look at the whole picture: mobility, medication, cognition, home setup, risk, before things unravel. Because prevention is always kinder than recovery and usually a heck of a lot cheaper. If you want to understand your own risk or your parents', you can find us at agebrightly.co.nz. And if this episode was helpful, please follow the podcast and share it with someone who needs to hear it. These conversations only matter if they reach the right people. I'll see you next time on The Next Fit.